What is up, ladies and gentlemen? Today we are going to be doing a short video about how Gluteus Maximus inhibition can actually lead to Patello-femoral arthritis if not treated for long periods of time. I'm Dr. Nick Spangler, and this is the practice report. Okay, so when we start talking about Gluteus Maximus, I'm going to call it Glute Max for the sake of syllables here. But so where and how does this occur? So the first place we want to look for this is patients who might present with lower cross syndrome. So this is a postural syndrome that's typically characterized by hypertonic hip flexor and hypertonic lumbar erector musculature. The other part of that, and this is sort of the cross of the lower cross, is that on the opposite sides, the other way, we see inhibited glute max and inhibited abdominal musculature. And as we can see from this graphic on the right here, this is where we get that lower cross, or why it's called that, because we basically see tight muscles across from each other and then inhibited muscles. Now this graphic says weak, and I don't like that they use the term weak because weak is a byproduct of this postural syndrome. The actual problem is that these muscles are inhibited. The person doesn't know how to use them, and the muscles being weak are a byproduct of that. Now, why does this happen? Well, really, we have to look no farther than society itself. So if we look at the workplace environment, many jobs require us to sit for long periods of time. When we look at things like social media and entertainment, we are on our phones, our tablets, our laptops for large parts of the day. When we go to other, leisure activities like sporting events and concerts, we can often find ourselves sitting for long periods of time. And the byproduct of that is that when we sit for long periods of time, that's not what our body is built to do. Our body is built to move around, be physically active. We see that the iliopsoas becomes in a shortened position for long periods of time, and this can cause spasms and hypertonicity of those muscles. And then when we sit on glute max for long periods of time and don't use it, that muscle becomes inhibited, and we've lost that mind-muscle connection there. So why do we care about this? Why does this muscle imbalance cause things like patellofemoral arthritis? So the first part of understanding this is breaking down the anatomy and biomechanics of the glute max and the hip and the knee. So the first question we ask ourselves is, what is glute max insertion and action? So if we look at this graphic on the right here, we see that glute max kind of starts up here on the posterior third of the pelvis, and then it wraps down. It actually becomes part of the iliotibial band. And then part of the fibers do actually insert on what's called the gluteal tuberosity of the femur. Now, the action of glute is actually to extend the thigh, so perform hip extension, specifically when we are in a hyperflex position. So, for instance, if we're doing squats, when we are in that very deep squat, the glute max is going to be our primary mover for getting us out of the hole. And then as we get closer and closer to neutral hip alignment, that's where quadriceps becomes much more active. The other action of glute max is that it's going to perform hip external rotation. So if we have inhibited glute max, that means that our body still has to perform hip external rotation. So what is the compensation that has to occur there? The compensation is that we see that the other gross external rotators of the hip, things like piriformis, and then the egoic region, gemellus, obturator internus, and quadratus femoris, all of these muscles are hip external rotators, but they now are having to do overtime because now the glute max, which is the largest muscle in the body, is no longer helping and aiding with hip external rotation. Now, all of these muscles insert onto the parts of the greater trochanter. And again, they're doing overtime, and they're much smaller muscles. So the consequence of this is that we get what's called a greater trochanteric pain syndrome. And essentially, it's just overuse of these external rotators that are now compensating for a lack of glute max. And we get irritation, inflammation, and swelling over that greater trochanter because these tendons are just so overused and irritated by how much work they're having to do. Now, it's not really shown in this graphic, but it's important to note what runs underneath that greater trochanter. And the consequence of that is that we see our iliotibial band here runs right over the greater trochanter. So if we have some inflammation and swelling and irritation that's right underneath the iliotibial band, that's going to push up on the IT band, and the distance of that band hasn't changed, but now, the length of that band hasn't changed, but now the distance it has to cover has been increased because now it's got something pushing up against it from underneath itself. And if we look at the IT band, this actually goes all the way down our lateral thigh and actually inserts itself onto the lateral condyle of the tibia. And then part of these fibers actually do create the lateral retinaculum of the patella. So, what's the consequence of this? So we don't have glute max firing. Now our external rotators are becoming hypertonic and overused. We get things like trochanteric bursitis or greater trochanteric pain syndrome. And then subsequently, this puts more tension on the IT band and can lead to things like IT band syndrome. But what we care most about is the short-term versus long-term effects. So I've just laid out some of the short-term effects, things like piriformis syndrome or greater trochanteric pain syndrome or trochanteric bursitis, and then IT band syndrome. Well, imagine that we had a patient come in with pain at the greater trochanter, but we never screened them for glute max inhibition. It'd be very easy to treat the swelling and inflammation of that area, but never actually address the root cause of it. So then what is the long-term effect of us not addressing that glute max inhibition? Well, going back to this lateral retinaculum, if over time this whole process just becomes more and more exacerbated, the external rotators are more and more overused, the greater trochanter becomes more and more inflamed, the IT band keeps getting tighter and tighter and tighter. Well, this lateral retinaculum is going to keep getting tighter as well, and it's going to start pulling that patella more and more laterally. Well, we know that patellar tracking is important because we have a groove in the femur, the patellar groove, where the patella moves in a very efficient manner to not grind the bottom cartilage of itself. So if we're getting that lateral tracking more and more over life, that's going to start grinding that cartilage, and voila, we get patellar arthritis if this goes on long enough and we grind that cartilage enough. And unfortunately, with most degenerative diseases like arthritis, once we've lost that cartilage and we've lost that tissue, there's no getting it back. We can only manage it from that point on. And that's really how glute max inhibition leads to things like patello-femoral arthritis. So how do we fix this? How do we stop this from happening? So the first thing we need to do is check the arthrokinetic reflex. So that's the image we see here on the right. So this is something you would have the patient laying prone, and you'd be having them perform a straight-legged hip extension. And specifically what you want to be doing here is you're going to have one finger in the hamstring, one finger into the glute muscle belly, and then you'd have your other hand with one finger over each lumbar erector. And as we can see here, we should see a firing pattern of hamstring to glute to contralateral lumbar erector to the ipsilateral. With patients who can't fire glute appropriately, they're going to skip glute max in this process. You'll see hamstring firing, then the contralateral lumbar erector, followed by the ipsilateral, and then the glute max will take over. This is an improper firing pattern, and it shows that this person really doesn't have the mind-muscle connection to fire that glute efficiently. So for these patients, you can perform a P to A hip mobilization, grade 3 or grade 4. Evidence would show that just performing this hip mobilization itself does increase glute max activation with needle EMG studies. As well, if you are trained and your state practice act allows you to, you can perform a grade 5 hip distraction MOB. Again, you should really only be performing this if you're trained to do so, your state practice act allows you to, and again, if the patient is willing to have you do this. So from there, what we need to do is retrain the glutes. I feel like I need to be like Donald Trump, like the glutes are huge. And that's really the key here. It's the biggest muscle in the body. And if we're not using it, as we can see, has very big impact on the hip and just quality of life in general for the lower extremity. So in our clinic, we start our patients with a quadruped hip extension with the knee bent, focusing on driving that heel into the ceiling. We're focusing on making sure that they can stabilize the pelvis, that they're keeping the torso flat, They're not compensating by rotating the hips. From there, we progress them to a glute bridge, double leg, progressing up to single leg. And then this isn't something that we typically do in our clinic, but for patients who maybe need to get back to work or have poor lifting mechanics, we will start doing things like step ups, squats, and lunges to start taking the lower extremity and the hip through full ranges of motion and checking for glute max activation throughout that. All of these exercises are excellent for promoting glute max inhibition. Promoting glute max activation. Hey guys, hope you enjoyed the video. I'll be leaving some references and links in the description of the video related to glute max inhibition, glute max activation, as well as greater trochanteric pain syndrome. That's going to wrap up the video, guys. We'll be back next week with another video of something, who knows what, but hope you all have a good week, and drop a like if you enjoyed. Thanks.